Good evening, everybody. Good morning, good afternoon, wherever you are. I'd like to welcome you to this new journal club by the International Academy for Clinical Hematology. I'm Mohamad MOHTY from the Sorbonne University in Saint-Antoine Hospital in Paris, and it is my great pleasure and a big honor, as usual, to moderate this journal club brought to you by the IACH. The Journal Club of the IACH are supported by a generous unrestricted educational grant from Takeda Oncology, whom I thank, and the scientific committee of the IACH has selected this recently published paper in the Lancet Oncology by Dr. FACON and colleagues, and this is about the updated overall survival results from the randomized open-label phase 3 trial testing daratumumab, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone alone in newly diagnosed multiple myeloma patient. Here you have the abstract of this paper, and I have highlighted in red the key messages from this update, because as you probably know, the MAIA trial has been already published in the New England Journal of Medicine, and here the investigators are bringing a longer follow-up, which actually showing a significant improvement in overall survival, which is quite unique in the field of multiple myeloma when using daratumumab in combination with lenalidomide and dexamethasone versus lenalidomide and dexamethasone. And these are patients who are not eligible to high-dose chemotherapy and autologous stem cell transplantation. And you can appreciate the median follow-up is rather long, 56 months, and actually the treatment progression, treatment until progression with daratumumab in combination with len and dexamethasone showed a significant reduction in the risk of death. And actually, this is the reason why this regimen has been approved by regulatory bodies and is now widely used in the so-called elderly or non-transplant eligible population. And you can see the very beautiful shape of the curves from this updated analysis. You can appreciate the hazard ratio of 0.53, roughly 50% improvement when it comes to progression-free survival. And this is really the major message from this updated analysis, the overall survival advantage with a hazard ratio of 0.68, more than 30% improvement when combining daratumumab with the backbone lenalidomide and dexamethasone. So these are really very exciting results. And when you consider the intention to treat population in the pre-specified subgroup analysis for overall survival, you can appreciate that, to make a long story short, all subgroup of patients are going to enjoy longer overall survival with this combination with Dara Len Dex. So with this background, with this summary, it is my great pleasure to welcome Professor Thierry FACON from the University Hospital of Lille in France. Lille is in the north of France, and he is actually the first author, but also the principal investigator of this major randomized trial, the MAIA trial, which represents a milestone, I would say, in the field of elderly myeloma treatment. And the other panelist is another highly distinguished friend from Belgium, Professor Mchel DELFORGE, who actually is not a co-author of this paper, because as you probably know, the rules in the journal club is to have either the first or senior author of the selected paper. And this panelist will be challenged by someone who did not participate to this work. So Thierry and Mchel, thank you very much for dedicating the time to contribute and participate to this IACH Journal Club. We are very pleased having you with us tonight.
Thank you, Mohamad. Thank you for the invitation. It's a pleasure to be here.
No, it is our pleasure. And I would like to remind all of you guys attending this broadcast that you can send your questions, your comments, your suggestions, either using the discussion chat box or the Q&A, and I'll do my best to share them with the panelists. So my first question today is for you, Mchel. And actually, so you heard my summary, you read this paper, you didn't participate to this specific analysis. So when you saw these results, what was your reaction? Was it a sort of a wow effect, or was it, oh, okay, another myeloma paper? So please.
Well, yeah, thanks you for asking this, Mohamad. Well, if I would have to be an opponent, let's be honest, it would be difficult to find very strong arguments against, let's say, the positive results from this study. The wow effect was with a New England paper in 2019, but another wow effect was also with when we saw the results of this manuscript. And the reason why is, first of all, I appreciate very much the work that Thierry has done over the past years for non-transplant eligible myeloma patients. But I mean, these results are really outstanding, and let's say these results are a big milestone for patients, and they raise the bar very high. And as you know, we look first at the control arm and see, okay, is this control arm reflecting what we know? And the control arm is Lendex with a median PFS now of 34 months. And when we look at a previous study also where Thierry was PI, the first study there comparing RD fixed duration or continuous treatment with MPT, median PFS, if I remember well, was around 26 months. So this is much better for a control arm, and then seeing a median PFS in the experimental arm that's not reached after a median follow-up of 5 years. I think we agree this is unprecedented. And this, of course, now translates into also a significant overall survival benefit. But that doesn't mean that there are no points for further discussion regarding these results.
But you can count on me, Mchel, to raise these points for discussion, because obviously the goal here is clearly to have a critical discussion about the paper being discussed. But I agree with you, this paper is really practice changing, and it is really very attractive. So Thierry, let me go back to you, and maybe can I kindly ask you to give us a brief history of this protocol, and why did you choose to go into this combination of Dara Lendex, whereas we know our Spanish colleagues went to Dara VMP. We'll speak later. We have already questions actually about something in combination, an antibody with VRD, for instance. So can you just clarify to our audience the scientific rationale behind this combination?
Thank you, Mohamad. So, you know, the rationale was quite simple, in fact. You mentioned the VMP and then VMP in combination with Daratumumab, and as we all know, Jesus Miguel several years ago did establish VMP as a standard of care, so that was a New England journal. Say the Spanish background, but the background for or several other countries, in fact, was VMP. For us in the IFM, as you said, and as Mchel said, we developed lenalidomide and low-dose dexamethasone, and this was published in the New England Journal a few years ago as well. So this was the so-called first study. So the first study, so the IFM background and the background for several other countries was lenalidomide on low-dose dexamethasone. So that was, quite logical, in fact. So we said lenalidomide on dex is not bad. It's the good standard of care, and so it was quite obvious that the idea to add daratumumab was evident in a certain extent. So what I can also say is that initially the Daratumumab company decided to move forward with the Dara VMP study first, because VMP was I would say the standard of care of the company as well, and then the Daratumumab lenalidomide and dexamethasone study came second. So this is the reason why the so-called Alcyon study was published before the so-called MAIA study. But so it's just a way to. Few years ago we had. Yes, Mohamad.
Yeah, so I think we have some problems with your connection, Thierry, but definitely I believe that it's clear that you have led previously the first trial establishing lenalidomide dexamethasone as a standard of care, and it was logical to add daratumumab and to build on this platform. Actually, the biggest debate we'll have tonight, and already the questions we are receiving are about this overall survival advantage. But before this, maybe I would like to ask you, Mchel, because obviously I'm sure you have treated patients with such combinations. What do you feel about the safety profile? Because it looks like, although the protocol, the trial included really a significant proportion of elderly patients, and some patients were really relatively, I would say, bad shape when it comes to kidney function, still, it looks to me that the safety profile was really very good. So can you just share with us your thoughts about the safety and toxicity of this regimen?
Yeah, so that's an excellent question, because in terms of, let's say, subjective side effects that patients experience, that is related to the use of the lenalidomide and the dexamethasone, as we know for many years. But on the other hand, we do know that adding daratumumab is not something that a patient will cause direct discomfort to a patient. Okay, there's the injections, but now they are the IV infusions are now subcutaneous injections, so that's, let's say, with very limited discomfort for the patient. On the other hand, we see that if we look carefully at the results, we see that the grade 3 and 4 neutropenia increases from 37% in the RD arm to 54% in the DRD arm. And also the risk for severe infections like pneumonia goes up from 11 to 19%. So the short answer is that the major, let's say, risk in terms of adverse events is an increased risk for infections. And we need to be very vigilant for that, because we're dealing with elderly patients. Since the tolerability is good, we aim for frail patients also, and we should keep in mind that there's still this risk for infection that can require also appropriate preventive measures.
I think when speaking about infectious complications, Mchel, you're probably emphasizing the deleterious role of dexamethasone. And obviously, we're really, all of us are struggling with this issue, but I think that is probably one of the perspective of this article about getting rid of dexamethasone, and maybe in order to structure our discussion, I'll bring this at the end. But for now, I would like to jump into all the questions we have already about the overall survival issue. So Thierry, there is an argument which has been ongoing on social media and Twitter, saying, well, it has been always difficult to show an overall survival advantage when it comes to multiple myeloma, except when actually a patient at time of relapse are not able to receive the optimal or the most appropriate treatment. So what was the situation here? Because I believe a significant proportion of patients actually received daratumumab at salvage, at time of salvage. Can you please clarify this issue? Because obviously this is an important topic.
No, you are. So can you hear me well?
Yes, absolutely.
Okay, I switched to the iPhone. So no, that's a very important question. I do not think that this particular study is different as compared to other studies for second line options and third line options, I would say. As you know, this is a very dynamic process. You have to keep in mind that this study enrolled patients between 2015 and 2017 in several different countries. So the access to daratumumab was not exactly the same across all countries. Then you have your control arm did quite well, median PFS about 3 years. So some patients just did not relapse. So when you see that the numbers we have seen today for patients receiving daratumumab for second line are not bad, in fact. So these numbers of patients will increase over time. So I think we cannot claim that the survival superiority of DRD was just related to the fact that not all patients did receive daratumumab for second line. And this is in fact something which is extremely theoretical. In this kind of situation, it's totally clear that you will not have 100% of patients just receiving daratumumab for second line, just because some of these elderly patients will progress and die. They will progress and not be able to come back to the hospital to receive daratumumab. Daratumumab could not be available, etc. So you have, it's this kind of analysis has always been difficult, in fact. And when you look at second line options across different studies, in fact, usually you find a lot of regimens, and it's not easy to find guidance but I think what we have today for Lendex control arm in terms of access to daratumumab for subsequent lines of therapy is not bad.
And actually, I think you are providing a fair explanation. And also, I think we can also emphasize the fact, because I myself am convinced, because although I'm just a moderator and I need to be fair, but I have also my scientific opinion and I'm convinced with these results. Obviously, the control arm here, the RD, is really a very good arm when we look to the PFS compared to what we used to have historically with RD. Mchel, what do you think? I mean, same question to you. What are you feeling about the fact that we can see an overall survival advantage, whereas, for instance, in other frontline myeloma trials, we didn't see overall survival advantage? Do you share Thierry's comments?
Well, I share his comments that it's a very difficult discussion because, of course, it's the strongest endpoint, but it is influenced by so many confounding factors. As we do know, the myeloma landscape has over the past years evolved so rapidly that this is impacting the choice of treatment at relapse. And also these studies are conducted worldwide, and we do know that access to different regimens outside of a study can be highly different according to where your patients are being treated. So honestly, I think this is kind of confirming the benefit of the regimen. But if you ask me which type of result convinced me most, then I must admit that it's more the PFS than the OS. The OSS reinforces the fact that the PFS is so much superior. So that is basically my honest answer. And yeah, the reason why we have other regimens have failed to show an OS is because of these confounding factors. And you mentioned Alcyone, so VMP versus Dara VMP. And okay, the OS significant benefit was also out there. But if you look at the PFS, so that's around 3 years. And then both studies
this is
show
what we
an
have
OS,
with Lendex here,
yeah,
just the control arm. Yeah.
Okay, so you have 2 studies showing a significant OS benefit, but based on PFS, I think the choice is obvious if you would have to choose between the 2 regimens. Finally, if I may, and that's also been raised by Thierry, especially in elderly patients, for the majority of patients, you only get one good chance to treat. And believing that you are going to solve the problem at relapse, where you have at your availability a highly active regimen up front, I think that would be a wrong decision.
And just as just a brief comment, I heard this particular comment from other colleagues. The median PFS will be 5 years, around 5 years. The median OS, we don't know, but will be, let's say, could be up to 7 years. But that's only 2 years, people will say. So in other words, even if you have a very good first-line regimen, and because we enroll more than 40% of patients aged 75 to 90 years, treatment options at the time of relapse remain, in a certain extent, a little bit limited. And so your gain is, you have a very substantial gain in terms of PFS, but then you may claim that we should do efforts to improve the clinical outcome at the time of the first relapse. But that said, again, these patients many of them are very elderly patients over the age of 75 years.
So I think here, Thierry, you're bringing another important aspect we all know in hematology, but most importantly in myeloma, especially when it comes to the elderly population. And this has been shown in American data from the Mayo Clinic, Arizona, Dr. Fonseca, from the UK by Dr. Kui Young, by Dr. Andrew Spencer in Australia, that actually a significant proportion of patients will not make it into the first relapse, and roughly 70% of your amount of survival, you gain it with your frontline. Still, Thierry, I'd like to continue to challenge you because we have a few comments from the audience, and one comment is actually a very nice one, saying, you guys, FACON, DELFORGE, MOHTY, you did talks telling us that in order to live longer in myeloma, you need to be MRD negative, which actually I can't deny. We have just written this, in a Blood paper 1 month ago. But then the comment is for you, Thierry, and I'd love to hear from Mchel. The percentage of MRD negativity in this trial is relatively modest. I mean, we're not close to the 50 or 60% we heard recently from the master trial, from the concept trial. So is there an explanation here, Thierry, or we just don't know?
No, I think that's a very nice discussion. To make very short a long story, I would say, MRD negativity is likely extremely important if you are diagnosed with myeloma at the age of 50. Because at the age of 50, you could say, if you want to achieve a great clinical outcome, at a certain time point, you need to be MRD negative. And but if you are diagnosed with myeloma at the age of 78, the MRD negativity I would not say this is not important at all, but it looks like it is less important. And this is something I looked at this at the very beginning of the study, and as you said, only 30% of patients are MRD negative at 10-5. If you look at sustained MRD negativity at 1 year, it's 15%. So you could say, why is there is a 15% sustained MRD negativity versus median PFA 5 years, which means that, but you know, you have 50% of patients in complete response. So in other words, you could say that if you are at the age of 80, if you can achieve CR, even possibly a good, very good partial response, something like that, you may enjoy a long PFS, and if you have a standard risk myeloma, you may achieve a great clinical outcome. So my only answer would be to say that, of course, if you can find something which is able to achieve 50% or more MRD negativity, that's great. But I think that the topic is not exactly the same in the very elderly patients.
Any thoughts on this issue of MRD, Mchel?
Well, you have clearly shown that in your paper. It's a very important hot topic, and if not yet discussed, I would encourage you to bring it in one of these future journal clubs. But it's definitely worthwhile a complete discussion. But I think Thierry made some very important points, and we should try to step a little bit away from this one-size-fits-all approach. And of course, MRD is a very important endpoint, and it's the best surrogate endpoint for PFS and OS we have. But that doesn't mean that all treatment decisions in future and currently, but maybe more in future, should be MRD driven for all patient categories. I think we all agree that in younger high-risk patients, the aim should be to bring these patients in an MRD negative status. But for an elderly patient who tolerates the treatment, the challenge is to keep them on treatment and to control the disease. And if you are able to eradicate disease, I would say that's an extra benefit, but it's not the primary aim in that subgroup of patients. It's more like controlling the disease without causing too many toxicities.
So this is very interesting, Mchel, because that brings me to a couple of comments we had about curability of multiple myeloma. And actually, Thierry answered this issue between the lines. What does it mean to be cured when you have multiple myeloma at age 76 or 77 or 78? And actually, I've just realized that based on what Thierry said, okay, we have a median PFS of 5 years, and then you have an OS maybe of 6.5 years or 7 years. So if you are age 76, diagnosed with multiple myeloma, with such regimen and the salvage regimen eventually, you end up dying at age 82, which is the life expectancy of a male at birth, I think in France and Belgium. So one may wonder, what does it mean? But this is really fascinating. We have here, and I'll direct this to you, Thierry, first, a nice question from Dr. Hira Mayan from Canada. Hi, Hira, and thank you for being loyal to the ISCH. And actually, she's bringing another important issue, and we at the ISCH are very keen about for advocating for patient, for accessibility, for availability, but also affordability of drugs. And the comment from Dr. Mayan is about the financial burden of these regimens, especially if you use them continuously. So this is the debate about fixed duration versus continuous treatment. And her speculation, or maybe question, is can we stop the monoclonal antibody at some point, as it has been done actually in the similar design in the Blood paper by Dr. Alessandra La Rocca, I think, last year. What are your thoughts, Thierry, about this suggestion? I know you didn't test it, but
Yes, no, the point is very well taken, and I think that this question of continuous versus fixed duration therapy will come back. You could say, in a certain extent, it comes back with DRD, but you mentioned the time we will have portisomip in combination with DRD. So at the time you will manage DVRD, let's say, in some patients, the question of fixed duration, so that will not be DVRD continuously. So interestingly, this question of fixed duration versus continuous, which appeared at the time of lenalidomide and dexamethasone, will have to be revisited as well at the time of 4-drug regimens, or even 3-drug regimens such as DRD. It has not been done, but you know, because you are the PI of a study looking at DRD fixed duration versus DRD continuous for patients with relapse, and that's a very important study, which will inform in a certain extent what we got in the frontline setting. To be honest, I don't know. The only thing we know is that when you give DRD continuously, you achieve median PFS 5 years and median survival likely around 7 years. So this is what we have. If you want to discontinue either lenalidomide, so the discontinuation of dex is another topic, and that it is currently done. It will be done more and more frequently. But then you may say, should I discontinue lenalidomide, or should I discontinue daratumumab? And what will be the conclusion of this? And that I don't know, to be honest.
So, Mchel, I think Thierry was fair saying, well, we didn't test it, so we don't know. But assuming today you would like empirically to do something or to modify this regimen, would you be willing to have a sort of a fixed duration, or how would it do? Because actually, although I personally would advocate for fixed duration treatment, you know, in the 77-year-old gentleman we were talking about a few minutes ago, it may be tricky because, you know, this guy has one chance, one shot to make it until 82, 83, or 84. So maybe you don't want to take this risk of having a relapse, which can be an aggressive relapse. So any thoughts on this, Mchel, in your practice?
Well, it is a very important discussion. And I asked myself the question, would I approach it the same way if these compounds, let's say, were for free? Because somehow I think the way we approach it is influenced by the fact that we do know these combinations are extremely expensive. And so that is something very important to take into consideration. But the approach should be driven by, okay, what is the best approach? Fixed duration, continuous duration, reduce or take out one drug. So indeed, you need studies like you have done, Mohamad, to approach this in a scientific way. But on the other hand, if we look at our patients, they start to some extent developing side effects. Rarely to the DARA, but of course there is this infection risk, but it's more frequently to the LEN. And okay, everybody approached this sometimes in a different way. And so a decent study should help us to guide how to do that. And I can imagine now that we have studies exploring DARA plus LEN as a maintenance treatment after stem cell transplantation. And okay, we already have seen the results from Griffin, and we see that this combination is very active. So to some extent, people will say, okay, then I take out dexamethasone and I put my patient on a kind of a maintenance with DARA and with low dose LEN. Whether that's the best approach, we assume it is, but again, we need comparative studies to explore this.
Actually, just to clarify to the audience, maybe you're not familiar, but the Griffin study where Professor DELFORGE was alluding to is the phase 2 randomized trial, which was published last year in Blood by Dr. Voorhees, comparing VRD to DARA VRD, and this is in the transplant eligible population. And actually we'll get an update with longer follow-up about this trial in the next ASH meeting in a couple of weeks. And I think I saw the abstract that will be delivered by Dr. Kaufman, this update. But obviously this is the transplant eligible population. That brings me, Thierry, to a question we have from Dr. Lucien Owens, asking actually about whether in a transplant eligible patient, but for some reason, you know, assuming the guy is refusing transplant, or you have some doubt about, you know, the general status or comorbidities, would you consider Dara-Lendex as the alternative?
You know, we had this discussion a couple of years ago with VRD, and I remember some of us say that I will get started with VRD if I have a young patient, but this patient does not want at all to proceed to transplant. Why not staying on VRD? So you might say the same for the DRD. If you provide, I would not recommend to do that. But if you know that if you give DRD to a patient below the age of 65, you will enjoy the median PFS will likely be quite the same. The median survival will be even longer because treatment options at the time of relapse will be likely better, and patients may receive transplant for second line or something like that, or other regimens. But I would not say this is not a recommendation from my point of view. But why not? But then you go back to this question of an expensive regimen we just discussed before for the elderly, and I just as a brief comment. So Mchel said that behind this question of continuous versus fixed duration for DRD, we have the cost, and because from a medical point of view, providing a low dose of lenalidomide on a monthly injection, sub-Q injection of daratumumab is not really a treatment burden for the majority of patients. And just to be honest, if I had to discontinue something in the context of this combination regimen, I would likely discontinue lenalidomide and not daratumumab.
Well, that's very clear. Thank you very much, Thierry. Here, actually, that brings me to another question we have from the audience. And again, it's a very nice and fair question. This is about the EHA-ESMO recommendations published earlier this year, I think February 2021, by Dr. Dimopoulos and colleagues, actually recommending in the non-transplant eligible population Dara-RD or VRD. However, my understanding, Mchel, that when we look to the VRD results in the SFOG 777 trial by Dr. Dury and colleagues, which is a sort of a mixed bag of many patient transplant eligible and non-transplant eligible. But when we focus on the group above age 65, which is the case of the MAIA trial here, the results of VRD are not really very exciting. You know, you have a median of 34 months of PFS. So why do you think, I know maybe I should ask the question to the panelists who made the recommendation, but just your thought, how do you feel about this issue of VRD? Because VRD is definitely a sort of a very popular regimen, you know, across the globe. And now in many places, portisomip is a generic drug. In few countries, you have lenalidomide generic. So obviously, I feel people are excited about it. What are your thoughts?
Well, it's also a very important question. And well, let me rephrase it to, first of all, do we still need portisomip for particular subgroups of patients, like those, for instance, with severe renal insufficiency or other specific subgroups where we say, okay, really, we want to give them a proteasome inhibitor. But when you look at the results with VRD, and the PFS is comparable with what we see with Dara VMP, although in that study, in this Alcyone study that you mentioned, VMP was given for a fixed duration of 9 cycles, but Daratumumab was continued. But despite the continuation of Dara, PFS, let's say, was comparable to VRD. So there's definitely something in the combination of Len plus Dara, as we know from preclinical data, so that there is probably this kind of synergistic effect. And okay, VRD is still, let's say, a very popular regimen because we frequently call it this backbone of a proteasome inhibitor, of an IMiD and dexamethasone. To, let's say, this backbone, we have built many treatment strategies. But yeah, if I can, I would like to hear from you or from Thierry if there are subgroups of patients for whom he would still prefer a proteasome based regimen, or at least a regimen containing a proteasome inhibitor.
Well, that's great, Mchel, because then you are facilitating my life. We have a couple of questions about who should not receive Dara RD, or whether there is room for Dara VMP, which is another approved regimen. And we know the value of proteasome inhibitors. We know the value of alkylating agents like melphalan or cyclophosphamide, especially when it comes to high-risk cytogenetics. So any thoughts on this, Thierry, beside maybe your first immediate answer saying no, Dara RD for everybody, but now giving it a little bit deepest thought, what do you think?
Okay, to be frank, I think if you have a strong contraindication to lenalidomide, I would totally accept to proceed with Dara VMP, for example. I may accept the fact that if you have severe renal insufficiency, some of us, maybe not me, but some of us may prefer to provide Dara VMP. But I think these exceptions are very limited from my point of view. It's always difficult to look at subgroups, but for example, if you want to look at poor cytogenetics in the MAIA study, there is some survival, not only PFS. So there is a strong PFS benefit for daratumumab in high-risk patients, but there is also, this was one of your slides, an overall survival benefit for patients with high risk. The hazard ratio is only 0.8, but it's not. It's some kind of benefit, and it's like, I'm not sure this is very different for Dara VMP or other daratumumab-based regimens as well. So, from my point of view, almost all patients should likely receive DRD at this time. Then, in few years from now, this discussion will switch to a DRD versus DVRD discussion, and so that will be for the end of 2022 or early 2023.
Okay, we'll come to this in the last part of the journal club. But Mchel, in your experience, who are the patient non-transplant eligible for whom you would choose VRD or Dara VMP, for instance?
Yeah, we prefer to give portisomip in patients with a creatinine clearance below 30 milliliters. And that's particularly driven by the plenty of publications that have shown us that bortezomib is the preferred regimen for patients with severe kidney failure related to multiple myeloma, well, because of not only the anti-tumoral effect, but also because of NF-kappa B inhibition, anti-inflammatory effects in the kidney. For those patients, we would start with Dara plus bortezomib, eventually add cyclophosphamide, but let's say, okay, our backbone is there, Dara, bortezomib, and we do not prefer those patients with Len up front.
But if I want to challenge a little bit, Mchel, just to do the opposite, interestingly, we have heard for many, many years that bortezomib is a nice drug for patients with renal insufficiency. So the Daratumumab company designed the Halcyon study, and one exclusion criteria was to have creatinine clearance below 40, which was greater as compared to what we had in the MAIA study. So in other words, we can claim that bortezomib is a nice drug for patients with renal insufficiency, but in the Halcyon studies, there is no patients with severe renal insufficiency. So this is a kind of, okay, I am not totally comfortable with that. Even so, I accept that based on the very large clinical experience we have with bortezomib for many years, of course, I accept that this is a nice drug for patients with renal insufficiency, but this is not, if the company had in mind that this was definitely true, they should have accepted to enroll patients in the Halcyon study with severe renal insufficiency and possibly having no exclusion criteria based on renal.
Well, no, I think if I can
yes,
briefly
please.
address it, I think it's fair, and again, the truth is somewhere in the middle, and I definitely do not want to claim that you should not or you cannot use lenalidomide in adopted doses safely in patients with severe renal impairment. But I think in studies like Halcyon, it's probably the melphalan, the old-fashioned melphalan, that's the bottleneck there, because we do know that if you give the melphalan to patients with severe renal impairment, you do not know which dose to give, and so that's probably, I think, a kind of bias in that type of study.
Yeah, no, thank you very much, guys. And actually, while we were talking about the different regimens, we have an important piece of information by Dr. Shasa Farhan. And by the way, Dr. Shasa, thank you for the invitation, because you sent me earlier an invitation to do a webinar. I'll reply to you. And the information is about that the SFOG is preparing a prospective trial comparing VRD light versus Dara-RD. And I think this is clearly an important and awaited trial. So now we're reaching almost the end of this fascinating journal club, guys. And Thierry, I would kindly ask you, okay, now I think you have the overall survival advantage with Dara-RD. What's next? The bar is very high.
That's definitely a good question. That's a kind of, from my point of view, this regimen is a kind of reset. So we have DRD. What should we do? How should we manipulate this DRD regimen to improve the clinical outcome of patients? And here you have, so some aspects are relatively simple. So we, as you know, we have an ongoing study trying to discontinue dexamethasone very early. But then the big challenge from my point of view is to either to replace the lenalidomide, and this could be done with a bispecific antibody, for example. And so we have to investigate the combination of a CD38 and a BCMA or something different bispecific antibody, which would be some kind of, let's say, chemo-free regimen for myeloma. Or you could say lenalidomide is still, it's an old drug, but it's active, and I will combine a bispecific with lenalidomide, and I may do a better job as compared to lenalidomide and daratumumab. So from my point of view, for at least for the elderly, because so this is a point you may want to discuss, but I am still convinced that CAR-T strategies will remain in a certain extent for the younger patients. So we have to play in the best possible way with bispecific antibodies, trying to, and that could be also something different. We mentioned DVRD, but the future might be a bispecific in combination with Len and Dara, because in DVRD, from my point of view, the weak part is the bortezomib at the end. So if you do, I don't know, teclistamab, lenalidomide on daratumumab or talquetamab or whatever, you may achieve a great job.
And actually, while speaking about the different trials and protocols, I'd like to emphasize that there is also a very important trial. We're waiting for the results, hopefully in the next year or few months, which is the IMROS trial in the elderly population using another anti-CD38, namely isatuximab, compared with VRD. And I think this is going to be another important piece of information. Same question to you, Mchel. If someone comes to you with a few $1 million and say, well, okay, how can we improve beyond Dara-RD? What would be your first choice to test?
Well, I would say that's quite an offer. But I think, and I, to some extent, repeat what Thierry already mentioned. I think, first of all, we should also focus on how to further optimize the DRD regimen. And it might be that for a certain subgroup of patients, maybe DRD is fine enough, but we really need to kind of make that discrimination. And on the other hand, for those who have not the most optimal benefit from DRD, indeed, we should explore other strategies. And that could be for fit patients to add a proteasome inhibitor, or as Thierry mentions, for other patients to add in a bispecific antibody. But I think for some patients, DRD is maybe the most optimal regimen they can get between efficacy and tolerability.
Just to echo what was said by Mchel, this is an analysis we have to do, and I think the last paper of the MAIA study will deal with that. If you have a standard risk myeloma, so excluding high risk myeloma, if you achieve, let's say, complete response after 4 to 6 months of DRD, this is possibly the best balance between efficacy, safety, and convenience. So you could say for standard risk patients, achieving a high quality response in a short period of time with the regimen, this is the best I can do. And I may take the decision of not changing this regimen. I will just say for this subpopulation of patients, in fact, no regimen is perfect, but this one looks like a very, very strong regimen. And I will not make efforts to switch with a bispecific, which will be another story, with another new drug, something like that. So this could be a kind of perfect regimen for some subgroup of myeloma patients.
Well, this has been really a fascinating discussion. I learned a lot. It is highly inspiring, guys, and you really did a great job. Historically, we used to say that the prognosis of young myeloma is always better, and this is where we see the major advances. But actually today, the conclusion is probably the other way around, because probably the elderly myeloma patient or non-transplant eligible are the ones who are going to enjoy a relatively long-term outcome. So it has been an amazing journey, and I would like to take this opportunity of the Journal Club, especially to highlight to our youngest youngest colleagues in the audience, wherever you are, that Professor FACON in the IFM group actually were the ones that in 2007 introduced and led to the approval of the MPT regimen, melphalan, prednisone, thalidomide, a major breakthrough in elderly myeloma. 7 years later, 2014, New England Journal of Medicine, introduction of the Lendex regimen, breakthrough, very popular worldwide. And now 2020 and 2021, we have seen the Dara Lendex. So the future looks very brilliant. And obviously you can appreciate that we need to have like a very ambitious goal and follow a very strong path. So thank you very much, Thierry. Thank you, Mchel. Because obviously when I say the IFM, it includes our friends from Belgium and some Swiss centers, French-speaking centers. So we are always in the myeloma community very grateful to these efforts. Thank you very much. We went slightly beyond time. Usually the Journal Club is around 40, 45 minutes, but this has been really a true pleasure to be with you guys tonight. And for the rest, I'd like to thank you all again for being loyal, for following the ICH activities. Today has been a relatively busy day because earlier in the afternoon, we had a fantastic webinar about COVID-19 and the latest updates. I hope you will, wherever you are, you will stay safe and keep well. We know the situation of the pandemic is not easy everywhere. So, but wherever you are, again, please stay safe and keep well. And I hope to see you very soon at some point in another IACH activity or in another meeting in person. Why not? Thank you very much and take care.
Thank you very
Thank you,
much.
Mohamad. Thank you,
Mohamad.
Mchel. Bye-bye.
Bye-bye. Bye-bye.